Please feel free to, I'm going to go through the talk, but please feel free, Raed, as the moderator.
I will be looking at the chat window and see if there is any questions, and will interrupt you when there is necessary.
Because I feel, you know, Jordan is, you know, we're all friends and family, so I'm happy to be stopped at any time. There's no formality here in this presentation.
Okay.
So in the Middle East region, you know, in the MENA region, congenital glaucoma is not an uncommon diagnosis. We see it more than most other parts of the world, except for maybe some parts of India. And most of us have no problem in making the diagnosis of pediatric glaucoma. And when we make the diagnosis, we're usually correct. It's very straightforward. But in addition to pediatric glaucoma being more common in this region, there are also some rare recessive diseases that are lurking among our pediatric glaucoma cases. And these rare recessive diseases have one or more features that are common to the features we associate with pediatric glaucoma. And these rare conditions are conditions that can be mistaken as pediatric glaucoma. You know, over the last almost 20 years now, I've had quite an experience with pediatric glaucoma, and it's difficult to deal with. It's not something that is, you know, easy to deal with. But one of the advantages of that is I've also gained an experience and an interest in some of these conditions that can be mistaken as pediatric glaucoma. And what I'd like to do with you today is share my experience over the last almost 20 years with these conditions that are hidden among our cases. Again, most of the time we have no problem making the diagnosis of pediatric glaucoma, but there are these conditions lurking out there, and anyone who takes care of children with pediatric glaucoma always has to think twice, take another look, be sure that you're not dealing with one of these mimickers. So, let's see. Again, pediatric glaucoma is typically a very straightforward diagnosis to make. What do we see in children with early onset glaucoma? We see megalocornea, we see corneal haze, increased measured IOP, decimase breaks, buthalmus, optic nerve cupping, myopic shift, et cetera, And we look at these parameters and we follow these parameters to make the diagnosis and follow children with pediatric glaucoma. And I've listed these parameters here that we use, and I want you to notice two things about what I've listed here in these parameters that we use. One is that I've put measured IOP on the bottom of the list. And the second thing is I put it in small font. Of course, IOP is important, but I think one of the biggest mistakes that is made is this over-reliance on IOP in assessing children with pediatric glaucoma. There are children that have glaucoma and the pressure doesn't measure high for a variety of reasons. And there are children who the pressure measures high in that don't have glaucoma. So for babies, for very young children, I'm actually looking at everything else first, and I look at the pressure last. The pressure is not something to be ignored, of course, but the overemphasis on the pressure is one of the pitfalls in managing pediatric glaucoma. Of course, you know, when you have a struggling child, if you even attempt to make a measurement of the IOP, it's going to be inaccurate. I see fellows and residents feel like they need to document something on the chart, and they'll hold the child down and try to force a pressure. That's the worst thing you can do. You take a normal child, hold them down, the pressure is going to measure 40. It's not true. So don't even measure the pressure on a struggling child. I don't like to take measurements of IOP in the operating room for surgical decision making, with very few exceptions. The anesthetics that we use affect the IOP. Intubation affects the IOP. Even the speculum affects the IOP. The only time, of course, when there are corneal opacities, this also affects the IOP. The corneal biomechanics are different. be very, very careful about this. Again, I try to make my decision about whether or not surgery is needed before entering the OR. I don't like to rely on IOP taking in the OR. The only exception to this, if the eyes are more or less similar and I'm comparing the two eyes between each other, I might use that finding. But I find it very difficult to make this. I find it misleading to make decisions based on the IOP measured under general anesthesia. Here's a little quiz I have for you. Which eye do you think has glaucoma? It's an 8-month-old girl with unilateral glaucoma. By the pneumotonometer, the pressure is higher in the right eye. And by the tonopen, the pressure is higher in the right eye. So which eye do we think has glaucoma? Well, let's take a look. The right eye measures higher, but the left eye has corneal edema, buphthalmos, -14 refraction, and vertical cupping. So I think you see my point. IOP is not something, the end-all be-all for determining whether or not a child has glaucoma. That's one of the biggest mistakes that I see made in managing these cases. I would call it the number 2 pitfall. That is to say, IOP measurement, over-reliance on IOP measurement is the number 2 pitfall in pediatric glaucoma. I'll save the number 1 pitfall in pediatric glaucoma for the end of this presentation. But please keep this in mind. If you remember anything about this presentation, don't over-rely on IOP measurement in making glaucoma decisions. So now I'm going to go through some cases that, in my experience, can mimic pediatric glaucoma. And we're going to start with the front of the eye and go to the back. And let's start with this girl who was referred for glaucoma surgery. Her older sister had surgery for glaucoma. She's on 3 different IOP lowering medications, and her pressures are still low in the low 20s. And she's referred for glaucoma surgery because the IOP cannot be controlled. And you can see her here. She has the corneal haze. Her IOP measures in the upper 20s, despite the drops. And you can see her here also. Now, you can understand why glaucoma was suspected or diagnosed, but immediately you should see that things are not fitting. And this is one of the things about pediatric glaucoma. We have to look at all of the parameters and everything has to make sense. This girl was diagnosed with congenital glaucoma, but you wouldn't have congenital glaucoma without some degree of ocular enlargement. And this child doesn't have any ocular enlargement. More than that, when we can refract her, and when we refract her, her refraction is hyperopic. There's no way that if a child truly had congenital glaucoma, there won't be some degree of buphthalmos, some degree of myopia. When we look more closely, this cornea, the haze in this cornea is not the haze that we typically see in congenital glaucoma. This haze, it's hard for you to appreciate, but it's a diffuse mosaic haze. It's different from what we typically see in congenital glaucoma. When we look at the slit lamp, it's an extremely thick cornea. This is not congenital glaucoma. This is a primary corneal abnormality. This is an endothelial dysfunction. This is recessive CHED. And her older sister, who had surgery for glaucoma, also had recessive CHED. So you have to be careful. Just because somebody had a history, I think this was one of the problems with this patient. She was coming with a history of glaucoma, and she was coming with corneal haze and high measured IOP. You have to be very careful. The sister had also been misdiagnosed and actually had surgery for glaucoma. She didn't actually have it. Congenital hereditary endothelial dystrophy is one of the most common conditions that can be mistaken for congenital glaucoma in the region. And it can be tricky when you have a newborn baby and the cornea is hazy and the pressure measure is high. You can understand why this confusion can occur. These children have a thick cornea and a characteristic mosaic haze. It's a very, very specific phenotype. Not all of the patients have high measured IOP, but some of them do. And again, it has to do with the corneal biomechanics. And when they have high measured IOP, they can be confused with glaucoma. This is very specific for mutation in a particular gene. Every single patient who I've seen with this condition has had mutation in that gene. And besides the fact that you don't want to operate on these children unnecessarily, another reason to identify them early, they do relatively good with corneal surgery if they have a significant amblyopia-inducing corneal haze. Here's a 7-year-old referred for persistent glaucoma. Again, her sister had a family history for congenital glaucoma. She's had multiple glaucoma surgeries since birth, OU, but her pressure still is in the low 30s. She's even had glaucoma complications, glaucoma surgery complications, blebitis, leaking blebs required multiple surgeries. Again, cornea, thick with mosaic haze, moderate hypoplasia, no cupping. This again is not glaucoma, it's CHED, and it's the same situation with the sister. Don't be fooled when somebody comes in with a history of congenital glaucoma. Sometimes they're carrying the same misdiagnosis. Here's a 10-year-old boy on chronic multiple anti-glaucoma drops. He's been on 3 anti-glaucoma drops for years and has been considered to have controlled glaucoma. Actually, he wasn't referred for glaucoma. He was referred for strabismus surgery. He had a right face turn and a null point, and he was referred to me for strabismus surgery. But when we examine him, he has iris and chorioretinal coloboma OU, and you can see the corneal haze. Now, anterior segment dysgenesis, anterior segment abnormalities is often associated with glaucoma, but not iris and chorioretinal coloboma. That is not associated with glaucoma. And when we look at his corneas, again, he's got thick corneas with that diffuse mosaic haze. Once again, this is not glaucoma, this is CHED. Be very careful about these patients. So that is my CHED is, I would say, one of the most common condition that's misdiagnosed as glaucoma. Right, I'd just like to say, I think that sometimes people have their microphones on. If everyone could keep their microphone muted as we go through the presentation.
Yeah, sure.
Okay. So here's the next scenario. A child with corneal haze sent for glaucoma surgery. I don't have pictures of this child's corneas to show you, but I do have pictures of his face. And when we saw his face, we started to ask some pointed questions. This child has had a history of multiple upper respiratory infections. He also has a history of joint laxity. This child has facial features that suggest a specific diagnosis. He's got the coarse features that we see in mucopolysaccharidosis, and indeed he has an undiagnosed mucopolysaccharidosis. That is a lysosomal storage disease where there's deposition of glycosaminoglycan throughout all tissues. And his corneal haze is because of this deposition of glycosaminoglycan in the cornea. This condition, this group of conditions, mucopolysaccharidoses, are not uncommon in the region, but it is uncommon for them to go to undiagnosed for many years. And we as ophthalmologists are in a unique position where we can suspect these conditions early because the subsets that involve the cornea come with corneal haze, and we have to keep in mind that one of the differentials for corneal haze is undiagnosed mucopolysaccharidosis. Now, this child didn't have glaucoma, but children with mucopolysaccharidoses have a risk for glaucoma, but it happens early. It happens later, sorry. Early on, the corneal haze in those that are susceptible to corneal haze is from glycosaminoglycan deposition. The glaucoma that can occur in this condition happens years later, not as an infant. Mucopolysaccharidoses, again, it's a group of lysosomal storage diseases caused by an inborn error of glycosaminoglycan deposition. There are different subtypes depending on the specific enzyme deficiency. They have characteristic facial features. Their ocular manifestation include corneal clouding, and again, This is why they can come to us early before a diagnosis is made. They have multiple systemic manifestations, again, all related to deposition of this glycosaminoglycan throughout tissues in the body. And it's not trivial to identify these children early because some subsets of this group of condition are amenable to enzyme replacement therapy. And enzyme replacement therapy is most effective when it's done earlier. Also, bone marrow transplantation can be useful. Here's another child with corneal haze sent for glaucoma surgery, and again, another undiagnosed mucopolysaccharidosis. Can you see those facial features that suggest the condition? The child did not have glaucoma. The child had deposition of mucopolysaccharide in the cornea. And yet another child, yes, go ahead.
Can I ask a question, Arif? So those patients, they came to you and they are not diagnosed with mucopolysaccharidosis,
no,
right?
Not the ones I'm showing you.
So the presenting feature was the corneal haze.
Well, they had some other things as well, but one of the things about undiagnosed, for example, the recurrent upper respiratory infections, that's something that happens in these conditions. The joint laxity, they have some developmental delay, but nobody's putting it all together. It's difficult because these are rare conditions.
Yeah.
But when you have that and the corneal haze, then, again, ophthalmologists are very uniquely able to suspect this diagnosis and bring these children to medical attention sooner than other providers. Let me show you this 33-year-old male. Now, this is a patient who complained of dry eye. And here he is. He's got short stature. He's got sensory neural hearing loss, obstructive sleep apnea, asthma, bilateral carpal syndrome. This patient is screaming at you, although he's gone for 33 years without a diagnosis, he's screaming at you mucopolysaccharidosis, or he's screaming at you storage disease, because all of these things are manifestations of storage disease. And there are attenuated forms of mucopolysaccharidosis that are never, ever diagnosed. And again, we as ophthalmologists are uniquely able to diagnose or raise suspicion for these conditions when they come to us with the corneal haze. So we have to take a step back and look. Corneal haze is a trigger. It's often a trigger for suspecting congenital glaucoma or pediatric glaucoma in young children, but it should also be a trigger for suspecting mucopolysaccharidosis. This is a useful review paper. There are obvious cases of mucopolysaccharidosis where the children are obviously dysmorphic from an early age, but there are many milder forms that really go undiagnosed for many, many years, and sometimes are never undiagnosed, which could have benefited from treatment. And again, here are some of the red flags for early diagnosis of attenuated mucopolysaccharidosis. And you can see it there, right there in the middle of the list, corneal clouding. Even if an adult comes in with corneal clouding, we should suspect the possibility of attenuated mucopolysaccharidosis. Take a step back, ask about the joints, ask about upper respiratory infection, carpal tunnel syndrome, things that are signs of storage.
Can we have one question from the audience, Arif?
Sure.
So, question from Dr. Luai. Can congenital glaucoma coexist in patients with CHED? I believe the answer may be yes. How do you make the diagnosis, if so, and how do you follow up these patients?
Yeah. I'm glad that point came up. Thank you, Dr. Luai. One of the things that bothers me a lot is people bring up this point about the CHED and congenital glaucoma, because I think there's one or two papers that describe the coexistence of these two diseases in one child. I want to say a few things about that. One thing is that there's absolutely no relationship between CHED and congenital glaucoma. CHED is caused by mutations in SLC4A11. Congenital glaucoma in this region is typically caused by mutations in CYP1B1, but not always. There's absolutely no relationship between those two. So having CHED gives you no increased risk of having congenital glaucoma, and having congenital glaucoma gives you no increased risk of having CHED. However, every now and then, we have a patient that can have two diseases. You know, we see it. A person can have diabetes and breast cancer. A person can have glaucoma and cataract. That doesn't mean that they're related to each other. They're just two different diseases coexisting in the same patient. It's uncommon, but because both CHED and congenital glaucoma exist in the region, every now and then you might get the rare occurrence of both diseases in one child. But much, 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 much more likely than that is the possibility that the CHED is being misdiagnosed as congenital glaucoma. That's much more likely than the coexistence of the two. So I'm not going to say it's impossible, because nothing is impossible, but it's very improbable, and it's much more likely that you have CHED that's being misdiagnosed as congenital glaucoma. I'll say some of these patients with CHED do get glaucoma because they have glaucoma surgeries, and then they get an inflammatory glaucoma from the unnecessary glaucoma surgeries.
As a complication, you mean?
As a complication. But absolutely 100%. I know people say this sometimes, that there's a relationship between the two, but I hope you understand why I'm saying there is no relationship. It's these two diseases exist in the region, and every now and then you'll have an unfortunate person that has two unrelated diseases. It's extremely rare, but it's not because they're related. It's just a coincidence if it happens.
Good.
So, and how to follow them, it's tough. I mean, there's no magic cookbook. For those of you who do strabismus surgery, it's like if you have patients who have strabismus and have congenital fibrosis of the extraocular muscle, you can put those tables that tell you how much to recess and resect, you can put those tables in the drawer. There's no book that's going to tell you what to do with those patients. And it's the same thing if you have a patient who really had CHED and congenital glaucoma. It's very difficult to follow. You can't rely on the IOP. You have to look at things like ultrasound and size of the eye. It's difficult. No straightforward answer for that.
Okay, good. Thank you.
Okay. Okay. I think you can see why this baby was suspected of having congenital glaucoma. This baby was referred for glaucoma management. Examined the child. Obviously, he has huge corneas. He has some myopia. He has borderline optic disc cupping. He has borderline IOPs. Is this glaucoma, or is this some kind of form of a megalocornea that's not glaucoma? It's tricky. It's tricky. How can we know? Well, one thing I can say is if you had a baby who really had this degree of megalocornea from congenital glaucoma, you'd have to see some kind of decime break. When you have a cornea that's more than 13 millimeters in a baby and there's no decime break, it's very, very, very unlikely you're dealing with congenital glaucoma. The other thing is there's no degree of corneal haze. Again, if this ocular enlargement was from increased intraocular pressure, you would expect some degree of corneal haze in a child this age. But still, it can be tricky. There's one other thing that can be very useful in these cases where you're not sure what's going on. I find something useful in a situation like this to make me feel better is to do ultrasound. Because children who have megalocornea as opposed to buphthalmos, they have a larger ratio of the anterior chamber depth to the axial length than the children who have buphthalmos. In the children who have megalocornea, the ratio of the anterior chamber depth to the entire eye length is greater than 0.2, whereas in buphthalmos, that relationship doesn't hold. The whole eye gets enlarged equally. And so this child, when we do the AC depth to axial length ratio, he's got a ratio well over 0.2. We've been following him. He's stable, rock stable. His maternal male cousins are similar. They also have large corneas. This is a child with X-linked megalocornea. He doesn't have glaucoma. Now you have to be careful about these children because just like with Mucopolysaccharidoses, who don't have glaucoma as babies, but they can get glaucoma as they get older, children with X-linked megalocornea, as they get older, young adults, they can get glaucoma. So they do need to be followed, but they don't get congenital glaucoma. They don't get infantile glaucoma. So megalocornea is in the differential of congenital pediatric glaucoma. It is often X-linked, but not always. Can be part of some syndromes. It's congenital, non-progressive, but they still have to be followed for the potential development of glaucoma. And checking in cases where you're not sure, you're suspecting it, but you're not sure, doing an axial length measurement, comparing the AC depth to the total axial length is a useful trick. Here's a 3-year-old girl referred for potential glaucoma. Again, she's got big corneas, but again, there's no haze. And even more importantly, and one of the biggest tricks of a pediatric ophthalmologist is that she's got a hyperopic refraction. You know, immediately you're not dealing with glaucoma because, you know, if you're going to have ocular enlargement from glaucoma, you're going to get some degree of myopia. Here's another child referred for potential glaucoma. This child is actually syndromic. He has some facial features. He's got also these stubby digit features. This child actually has Rubinstein-Tabby syndrome. And the interesting thing about Rubinstein-Tabby syndrome, they have megalocornea, they have optic decupping that mimics glaucoma. They can look like they have glaucoma, but they really don't have glaucoma. Although, again, they're at risk for glaucoma. So it's a tricky situation when you have a patient with Rubinstein-Tabby syndrome because they often have megalocornea and optic discupping that's not glaucoma related, but they are also at risk for getting glaucoma, a tricky diagnosis. Moving right along. Here's an infant boy referred for glaucoma surgery. And again, you can see why he's suspected of having glaucoma. Now, this condition is one of the conditions I really, really want to highlight to the audience, because this is a condition that is very important for the region and often has inappropriate surgery done with disastrous results. This child was suspected of having glaucoma, not only because he has huge corneas, but he also has increased intraocular pressure when the pressure is measured. But he doesn't have enlarged corneas from increased intraocular pressure, because remember what I said, if you have increased cornea size from increased intraocular pressure in infancy, you're going to have some degree of corneal haze, you're going to have some corneal break. This child has none of that. He has a congenital megalocornea, okay? But I just told you he also had high measured IOP. This high measured IOP is because part of his anterior segment malformation is not only megalocornea, but it's also a zonular weakness. And in young children, the vitreous is very firm. And if you have a zonular weakness, there's a tendency for the lens to move forward and cause an intermittent pupillary block glaucoma. And that's what this child had. He had an intermittent pupillary block glaucoma because the zonules were fragmented, and every now and then, depending on his position, the lens would move forward, cause a pupillary block, raise the IOP, he would change his position, the block would be broken. This is a unique condition that exists here in the region. It's a congenital megalocornea with zonular weakness. The treatment for this is not the traditional glaucoma surgery where we do surgery on the angles. The treatment for this is removal of the lens. That's the only way to treat this condition because the problem in this condition is the lens. And sometimes these children present with the lens in the anterior chamber. And if you see, because of the zonular weakness and because of the propensity of the vitreous to push the lens forward. So if you see a child who has huge corneas and the lens in the anterior chamber, this is the condition you're dealing with, megalocornea with zonular weakness. And here's his younger brother. His younger brother presented with the lens in the anterior chamber, and look at the size of this cornea. This kid is only about 8 months old. This is a primary megalocornea with zonular weakness, secondary lens-related glaucoma, sometimes misdiagnosed as primary congenital glaucoma, mistreated with angle surgery with disastrous results. This is from mutations in the gene LTBB2. Again, these children have congenital megalocornea. They have a zonular weakness with tendency for anterior lens movement and a secondary glaucoma. When it's mistaken as primary congenital glaucoma and angle surgery is done, the results are disastrous. They're really disastrous. Appropriate management is lens removal. And this gene LTBB2, it interacts with fibrillin-1. We know fibrillin-1, of course, when mutated, causes Marfan syndrome, which is classically associated with ectopia lentis. In these children with LTBB2 mutations, all the zonules are fragmented, and rather than just ectopia lentis, the lens tends to move forward into the anterior chamber. So here's one of the first children that I saw. I didn't see him primarily. I saw him referred. This is a child who was diagnosed as primary congenital glaucoma, and he had bilateral angle surgery under one setting. And 1 month later, he had bilateral retinal detachment with the lens in the vitreous bilaterally. Because he never had angle surgery, you muck around in there, the lens is not stabilized, it goes back, causes a secondary retinal detachment, a disaster. I can understand why this patient was suspected of having primary congenital glaucoma, but remember what we said now. No decimate break, no corneal haze, no way in an infant is this enlargement from increased intraocular pressure. Confusing because when you measure the pressure, it's high, but it's because there's an intermittent pupillary block. High pressure is not what caused the corneal enlargement. This is an anterior segment dysgenesis of megalocornea and zonular weakness. Here's another child. Again, he's 6 years old. Lens that came in with acute glaucoma. Look at the lens in the anterior chamber. I don't know if you can see here, he's got subluxation here of the lens. Again, look at the size of these corneas. This is LTBB2 related megalocornea with zonular weakness. It's a little bit easier to understand that that's what you're dealing with when the lens is in the anterior chamber. But when you just have a little bit of lens subluxation, be careful. Or even sometimes the lens doesn't seem subluxated. It seems like it's a primary congenital glaucoma, but it's not. This child is a really interesting case and really just brings home the point of how this can be confused with primary congenital glaucoma. It's a 3-month-old boy referred for glaucoma surgery. He's got tearing, photophobia. His IOPs are around 40 in both eyes. His corneas are large with haze. He's got haze because his IOPs are very high. He's got a myopic reflex, difficult to quantitate the refraction, vertical cupping, difficult to view. So I just put him on some medications and I wanted to reevaluate him because, as I told you, I like to do a complete evaluation on these children I suspect of having glaucoma before surgery. I don't like to make decisions in the operating room. And I didn't feel comfortable that I had a good refraction on him, so I brought him back. So put him on COSOP, which is dorzolamide timolol, for a week. And he came back, and to my surprise, in a week, he was much more comfortable. And his IOPs were 10 and 8. He was so comfortable I could retinoscope him. He's minus 26, but his fundus is not myopic. What is going on here? Well, this child had LTBB2 related congenital megalocornea with zonular weakness. When he came to me here, he had a sustained episode of pupillary block, and getting the pressure a little bit lower relieved the block. And you can see here his ectopia lentis. His high myopia is from the lens being forward. It is not from axial elongation. His fundus is not myopic. This is LTBB2 related congenital megalocornea with zonular weakness. Had this child had conventional glaucoma surgery, angle surgery, a disaster. Really be aware of this condition. It's very important in the region. I really want to stress that because it's still under-recognized.
Dr. Arif?
Yeah.
So a question from the audience from Dr. Muhammad Al-Shamrani. His question in LTPB1 related mutation, is the megalocornea primary or secondary to attacks of high IOP?
Yeah, it's LTBB2, and the megalocornea is primary. It is a primary. LTBB2 mutations cause two things. One is a primary megalocornea, and these corneas are over 13 millimeters. It's not subtle. So there's no in between. If you have a cornea of 12 millimeters, it's not LTBB2. The cornea is, it's always huge. It's always 13 or more. And the zonular weakness.
How about LTPB1?
No, LTBB1.
Also primary or secondary?
No, that doesn't cause LTBB2. It's not LTBB1.
Okay.
There's no, it's LTB. There is a protein LTBB1, but it doesn't cause this phenotype.
Okay. The other question in the LTBB1 and 2 related ectopia lentis, how can you differentiate it from other causes of ectopia lentis like Marfan?
Well, two ways. First of all, you've got the huge cornea, over 13 millimeters. Yes. That doesn't happen in Marfan. So you always have that huge cornea. It's part of it. So if you just have ectopia lentis and the cornea is not large, you're not dealing with LTBB2. Okay. And the second thing in Marfan, you know, I've always meant to study this, but we didn't study it in a systemic fashion. In Marfan syndrome, first of all, you don't have this huge cornea enlargement. Secondly, in Marfan syndrome, the lens doesn't tend to prolapse into the anterior chamber. It's not impossible, but it's very unlikely. That doesn't tend to happen in Marfan. Thirdly, the ectopia lentis in Marfan typically happens at the youngest 6 or 7. There are cases where it's younger, but usually they're 6 or 7 at the youngest. Whereas in this, it's happening in infancy. So they're different phenotypes. And of course, with Marfan, you have all of the other features. In Marfan, the cornea tends to be flat. The Ks are usually less than 40. LTBB2, we've meant to study it. We never did. But my sense is they don't have those flat corneas like Marfan. So these are some of the ways you can tell the difference. Thank you for the question.
Yeah. Can proceed forward.
Moving right along. Here's a girl referred for glaucoma surgery. You can see the corneas seem kind of large. You can also see there's sort of a bluish discoloration to the sclera. She actually recently had a minor trauma to her left eye, and she actually has a corneal break, a decimate break. I think part of the reason why when this patient was referred, it wasn't recognized that this decimate break was acute, related to the trauma. And it was thought that this decimate break was related to glaucoma in the context of a large cornea and a discoloration, maybe thought that the sclera was thin, causing this bluish discoloration. Now, just looking at the picture, could that be a Habe stria? That is a break in decimate membrane from increased intraocular pressure. Theoretically, it could, but practically speaking, Habe stria are usually horizontal. They're usually they don't come acutely. They happen much younger age. They don't happen at this age. This child doesn't have glaucoma. This child has a disorder of corneal fragility. And because of this corneal fragility, there's a bit of a keratoglobus. And because it's so fragile, a minor trauma causes a corneal break. Not a corneal break, a decimate break. And this condition is something called the brittle cornea syndrome. These children have a primarily ocular phenotype. They can have extraocular manifestations like joint laxity, scoliosis, and some other things, but it's primary ocular. And these patients sometimes get misdiagnosed as pediatric glaucoma because they have this corneal ectasia. It looks like it's kind of like an ocular enlargement. They can get breaks in decimate membrane from minor trauma. It looks like it's a Habe stria, but it's not. It's a disorder of corneal fragility. These patients are sometimes, when the condition is recognized, they're called Ehlers-Danlos syndrome, but it's not Ehlers-Danlos syndrome. It's brittle cornea syndrome, and the difference is that it's primarily ocular, and sometimes there are systemic features. Whereas in Ehlers-Danlos syndrome, it's primarily systemic, and very, very rarely are there ocular features, but the ocular features are not like this. So brittle cornea syndrome is another condition those of us who practice pediatric glaucoma in the region need to be aware of. These children have thin ectatic corneas. Sometimes they get keratoglobus. These corneas are prone to rupture. They're very difficult to repair. It's really very bad if they get a corneal rupture because the tissue doesn't hold well. It's really primarily an ocular phenotype, but they can have extraocular features, especially with time. It's from mutations in at ZNF469 often, but I've seen patients with PRDM5 mutations as well. And here's another child. You can see, look at the size of that cornea, okay? You can see why there's the thought of glaucoma came up. But it's ectatic. Look at the thinning. Do you see the thinning there with the slit beam? This is an ectatic cornea. It's a primary corneal problem. It's not a secondary enlargement of the cornea secondary to intraocular pressure. It's a primary ectasia. And when we take a look back at him, this child actually had multiple skeletal abnormalities as well. These children can have usually have a primary ocular phenotype, but sometimes they have systemic connective tissue disorders as well. But those are really secondary to the ocular phenotype. I don't mean it's caused by the ocular phenotype, but I mean it takes a back seat to the ocular phenotype. It's the ocular phenotype that's the worst thing in these patients, which is why the name of the condition is brittle cornea syndrome. It's named for the eye, not for the body. Here's a patient who had been diagnosed as congenital glaucoma, who's an adult now, lost his eye to glaucoma surgery in the left eye. You can see here this decimate break, an old decimate break, but in fact, he had brittle cornea syndrome. He never had congenital glaucoma. He was diagnosed as congenital glaucoma because he had breaks. I presume he had the same kind of break in the other eye. He ended up with a tisical eye from glaucoma surgery in that eye. In this eye, fortunately, no one touched it. He had brittle cornea syndrome confirmed by genetic testing. He never had glaucoma. I'll just take a minute for this point because it's one of these points that irritates me a little bit. These children are often called Ehlers-Danlos syndrome or Ehlers-Danlos syndrome 6, but Ehlers-Danlos syndrome is a different condition. It's a systemic condition. There are many different types of Ehlers-Danlos syndrome. There is one type, type 6, that has some ocular features sometime, but they're minor and they're not significant. It's completely different from brittle cornea syndrome. The other forms of Ehlers-Danlos syndrome, I don't know, maybe there are up to 15 different forms. Most of them don't have primary ocular findings, but type 6 can. And here's a girl with type 6 Ehlers-Danlos syndrome. You can see her sort of myotonic facies. She's esotropic. She has she's -20, myopic fundus, and she has severe scoliosis that she's had since an early childhood. These children are not subtle. They have obvious connective tissue disease. They don't have really that bad eye problems, as opposed to brittle cornea syndrome, which comes to us as ophthalmologists, misdiagnosed sometimes as glaucoma, and sometimes lumped in and called Ehlers-Danlos syndrome, but it's not. It's brittle cornea syndrome. Okay, moving along. Here's a boy with neurofibromatosis type 1 referred for glaucoma surgery. Now, how can this be a mimicker? This is neurofibromatosis. We see a plexiform neurofibroma. We can see the ocular enlargement. There's no doubt that children with neurofibromatosis type 1 are at risk for glaucoma, and especially if they have an ipsilateral plexiform neurofibroma in the lid. Those children are particularly at risk for glaucoma. But I want to highlight that in children with neurofibromatosis, especially the orofacial neurofibromatosis, there is a phenomenon known as regional giantism, where the tissues are overgrown. And sometimes the eye is big from that phenomenon, and it's not from glaucoma. And that's the case in this boy. This boy doesn't have glaucoma. He has regional giantism, because in neurofibromatosis, sometimes you get this sectorial enlargement of some body parts, some tissue. And when it happens to the eye, it can look like glaucoma, but it's not. Now, you have to be very careful here. As I just said, as I was very careful to say, there's a very high risk for glaucoma in this child. But at this point, he doesn't have glaucoma. He has regional giantism. This is just a point I want to highlight, because we don't want to be aggressive and treat a child like this for glaucoma with surgery when they don't really have glaucoma. So we have to be very careful and make sure we're not dealing with regional giantism in this setting. Orbitofacial neurofibromatosis and regional giantism, NF1 mutations has wide variable expressivity. Orbitofacial neurofibromatosis is a localized phenotype, and regional giantism can occur without glaucoma. Just remember that point. Don't jump to the conclusion that the child has glaucoma. Although they often can get glaucoma, be careful, make sure we're not dealing with regional giantism. A large eye in neurofibromatosis, when you have the orbitofacial form, is not automatically glaucoma. Okay, how are we doing? People still with me?
Yes. Hope everybody is still awake. Everybody is doing good. We have plenty of questions, Arif, so far, so I want to go through most of them so we can move forward, okay?
Yeah, sure.
So starting with the last things about the brittle cornea syndrome, have you ever tried or thought about cornea cross-linking in a brittle cornea? This question from Dr. Ibrahim Shahade from Jordan.
That's a very interesting thought. It's a very rare condition. I think there was one case report in the literature. I personally don't have any experience. These corneas are so fragile. I think you have to have very strong nerves to do that. But it's a very interesting concept. I know there's a case report in the literature. I personally don't have experience.
Right. And the other question about HAPS stria, is it always necessary to be horizontal, or can it be vertical in glaucoma?
No, it's not. It doesn't have to be horizontal, but it usually
can occur as a vertical from birth trauma, but can it occur in glaucoma?
I won't say never, but it's unlikely. It's usually horizontal or oblique.
Yes, oblique.
It's typically not vertical. When you see vertical, you have to think of something else, like brittle cornea syndrome or a birth trauma, forceps delivery. You can't say never. Again, this is the thing about pediatric glaucoma. You have to look at everything. If I saw a vertical break in the cornea, I'm suspicious that it's not glaucoma. But then if I see optic nerve cupping, if I see the pressure is very high, I see the corneal haze, I see the myopic refraction, then, the evidence is going towards glaucoma.
Okay, so glaucoma is a syndrome rather than being a disease per se.
Yes, you have to look at everything. So the answer to the question, very unlikely to happen, but I can't say impossible.
Right, and the other question, how to differentiate a brittle cornea, how to differentiate haps stria or brittle cornea from glaucoma?
Well, first of all, the habstria is going to occur within the first few years of life. It's not going to happen for the first time in a 5-year-old or a 6-year-old. And it's not going to happen for the first time in adults. The habstria is typically near the central part of the cornea, typically. It's not in the periphery. And if we go back to this adult patient, see, these breaks here are kind of in the periphery. Now, it's not impossible. I'm not saying, you always have to talk about probability, but right immediately, I'm suspicious that that's not glaucoma because of its location. Typically, you see my arrow, correct?
Yeah, of course, yeah.
Yeah. So, typically a habstria would be curvilinear here, like this. It's close to the visual axis usually. Immediately, I'm thinking, now, nothing is 100% and uncommon manifestations occur. So don't quote me as saying, Khan said if its break is here, it can't be habstria. I'm not saying that. I'm saying I see this and I'm suspicious that it's not because of its location.
Unlikely, you mean?
So yes, I mean unlikely. So habstria is typically in the center. It's curvilinear. You typically see 2 lines. You typically see some scarring around it. You typically don't see it acutely. Whereas other breaks in Descemet membrane can be more vertical, and when it's from corneal fragility, it can happen almost at any age. It's not only in infancy. But I wouldn't want to make a diagnosis of glaucoma or not glaucoma by just looking at the break in Descemet membrane and deciding, oh, that looks like a habstria. As we've said a few times now, we have to take everything together and put the puzzle together.
Right. The other question is from our colleague, Dr. Muhannad Levdour. What is the ideal glaucoma surgery in neurofibromatosis children?
Oh, tough one. That's a whole lecture in itself. I'll just say that every case is unique. You have to look carefully when you have it associated with this neurofibroma. And it's associated with the plexiform neurofibroma. I might lean more towards tubes, but this is a whole different discussion, and different people will have different opinions.
Right, and the other question also, some kids with glaucoma, their refraction is maybe hyperopic or near emmetropia. So do you think this is a valid statement? Do you think it's okay?
Well, I have certainly seen children who are hyperopic who have glaucoma, but I have no doubt that they started from a much higher hyperopia, and then they became less hyperopic. By far, it's unusual. And another thing I've tried to say a few times in this talk is nothing is set in stone. Everything is probability. Yes. So I'm not saying that if a child is not myopic, it can't be glaucoma. I'm not saying that.
So it can happen.
It can happen, but it becomes less likely. Unlikely things happen sometimes. Much more likely is that there's going to be a degree of myopia. In the cases of CHED, when they had corneal haze from infancy, and now they're 7 years old and they're hyperopic of +4, no way. That's, They would have had to be like a hyperopia of maybe +10 or something in the beginning, and maybe they went to, it just becomes unlikely. So you have to put together the puzzle and put together the story according to likelihood from looking at all of the pieces and all of the history. You don't take any one thing in isolation.
Okay, so we'll also ask the last question for now. Do you come across arrested glaucomas?
Very rare, but it happens. There is a phenomenon of self-arrested glaucoma. A child can even have habestria, and the glaucoma stops. I considered a late development. The angle didn't develop properly, but it developed late. It's rare. It happens though. It's not a diagnosis I would jump to. I would follow that child very closely and very carefully for some time before making that diagnosis.
Okay. Okay, we can move forward now.
Okay, so let's move to the back of the eye now and coming closer to the end of the presentation. There's a variety of optic nerve congenital abnormalities that can be mistaken as glaucomatous cupping. And of course, with a good exam, we would pick up most of them. But I want to go through a few that tend to be confused with pediatric glaucoma. And here's one, a 6-month-old boy with large corneas and large cups referred for glaucoma surgery. You can see his large corneas here. You can see his cupping. I think you can even appreciate here he's got a nerve fiber layer defect. Okay. But this child doesn't have glaucoma. What does he have? He has a hyperopic refraction. He has IOPs of 10 that have been stable, so the whole picture doesn't fit. What we notice about him is he's got a small head. He's got microcephaly. In fact, this child who is premature has an abnormality of brain development that we don't see uncommonly in children who are premature, periventricular leukomalada, and he has a form of optic nerve hypoplasia that's associated with periventricular leukomalada that's associated with optic nerve cupping rather than small discs. I mean, the caliber of the nerve is still low, but instead of the nerve itself being small, the disc is normal size and the cup is large. It's a static optic nerve hypoplasia that's associated with periventricular leukomalada. So optic nerve hypoplasia and periventricular leukomalada, I think that this quote from one of the early papers describes it well. Optic nerve hypoplasia in children with periventricular leukomalada is often associated with a normal-sized optic disc with a large cup. This unusual form of optic nerve hypoplasia most likely results from transsynaptic degeneration of optic axons caused by primary bilateral lesion in the optic radiation. I'll tell you right now, there are children or young adults in glaucoma clinics that have been diagnosed with low tension glaucoma that actually have this diagnosis. This is another condition that is really commonly, in my experience, misdiagnosed as pediatric glaucoma because they have optic nerve cupping. They even have visual field defects, but they're static and congenital, and they're not glaucoma. Here's a 13-year-old boy with a history of prematurity, visual field defects. You can see the cupping, why he's thought to have glaucoma, but in fact, he's got periventricular leukomalada. This is a static form of optic nerve hypoplasia that manifests primarily as cupping. Again, these kids, if our glaucoma colleagues look at their low vision, low tension glaucoma patients and ask if there's a history of prematurity, they'll pick up some of these cases. Here's a 7-month-old boy with suspected glaucoma, and you can see why he was suspected of having glaucoma. But when we look at these discs, you can see they're not glaucomatous discs. they're dysplastic discs, and actually they have a very interesting morphology. For one thing, all of the disc is empty. Usually we have vessels exiting from the center of the disc. The center has no vessels. All of the vessels are entering from the side. And there are multiple vessels entering from the side. Not only this, the whole retina looks ischemic. This disc is a very characteristic appearance. It's a so-called vacant disc, and it's the disc associated with the optic nerve dysgenesis known as papillorenal syndrome. It's a disorder of vasculogenesis that affects the eye, the optic nerve, and the kidney. And it has a very, very characteristic vacant disc appearance, and multiple vessels exit from the center, which are cilioretinal vessels. Basically, there's an underdeveloped central retinal artery circulation. There's no central retinal artery, and the retina is being supplied mostly by cilioretinal arteries. This very, very distinct phenotype is very specific for papillorenal syndrome. Sometimes it gets misdiagnosed as glaucoma. And sure enough, in this kid, when we do Doppler imaging of the kidneys, he has hypoplastic kidneys. So papillorenal syndrome is a disorder of disorder of vasculogenesis, sorry. It's characterized by optic disc and kidney abnormalities. It's from mutation in this gene, PAX2. And the optic disc abnormality is characterized by this vacant disc appearance, an absent or minimal central retinal artery, and multiple cilioretinal vessels. If you ever see that, it is really specific for this condition, and the patient should have kidney imaging. As I mentioned before with the optic disc hypoplasia from periventricular leukomalada, if you go to glaucoma clinics, you'll find some patients diagnosed as low-tension glaucoma who actually have that diagnosis. It's the same thing with this syndrome. You'll find some patients, you go to glaucoma clinic, find some patients who have low-tension glaucoma, who have been diagnosed with low-tension glaucoma and idiopathic renal failure. You're dealing with this diagnosis. Again, it's static in terms of the optic nerve. They don't have a progressive disease. It's not glaucoma. The optic disc appearance is most characteristic for the diagnosis. It's even more specific for genetic testing, because not all patients who have this characteristic appearance have the mutation, but they do tend to have the kidney abnormalities. So here's a 10-year-old girl referred for strabismus, abnormal head position, and nystagmus. She was also suspected of potentially having glaucoma, but immediately our suspicion goes down because she has a hyperopic refraction. And we look at her discs. It has this characteristic vacant appearance with the multiple vessels. Send her for PAX2 mutation. She's positive, and she has hypoplastic kidneys. Papillorenal syndrome, ophthalmologists are more able to diagnose this condition than anybody else because the disc appearance is characteristic and it's more specific than genetic testing. Moving right along with the back of the eye, here's a 5-year-old boy referred as glaucoma suspect. And you can see those big cups, why he was referred as a glaucoma suspect. But what else do we notice about this picture? Not only are the cups big, but the discs are large as well. And you can judge that by looking at estimating the size of the disc and the disc to fovea distance. Usually it's at least 2.5 disc diameters. It's less in this patient. This child has megalopapilla. He has a big optic cup, and children with big cups have big discs, and they have the same number of axons as a child who would have a regular sized disc and a regular sized cup. These patients sometimes get referred to as glaucoma suspects. It's a congenitally anomalous optic disc, an increased disc area with a normal rim area, rim volume, and retinal nerve fiber layer. Again, judging the size of the disc versus the distance of the disc to the fovea is helpful in making that diagnosis in children. Something else we can do these days is OCT and measure the volume of the disc, and that will also give us the diagnosis. So I think we're coming to the end now. I have one more case I want to share with you. And if you remember in the very beginning, I said that over-reliance on IOP is the number two pitfall in pediatric glaucoma. Now I'd like to go to the number one pitfall in pediatric glaucoma. And here we have a true case of pediatric glaucoma. There's no pseudoglaucoma here. This is really glaucoma. This is a girl who came in with unilateral glaucoma in the right eye, sensory exotropia, optic disc cupping, other eye is fine. We did glaucoma surgery on her, trabeculectomy at the time in this right eye, got the pressure down to very nice levels without any drops, and even got the optic disc to reverse cupping. We can see that in young children. If we get the pressure down to a good level, we can actually see reversal of optic disc cupping. But this child has been stable for years. Pressures in the low teens in the right eye. But this child was a complete failure. Why is that? Because despite the fact that we got the pressure down and we even got reversal of cupping and everything looked great anatomically, there was absolutely no compliance with amblyopia treatment. And this is the number one issue in pediatric glaucoma and pseudoglaucoma, is the issue of amblyopia. If these children, these preverbal children, are not given their proper refractions and they're not treated with their amblyopia at an early age, even if we have beautiful cups and we have beautiful IOP, we have blind eyes from lack of amblyopia treatment. And this is the most important issue in pediatric glaucoma and pediatric pseudoglaucoma, the issue of amblyopia. We cannot neglect this. Even though the children are not verbal, we have to refract them and treat them appropriately. Otherwise, all our efforts are lost in terms of controlling the IOP. So to summarize now, I've come to the end of what I wanted to present. Elevated measured IOP, corneal haze, large corneas, and optic disc cupping are not exclusive signs of pediatric glaucoma. Most of the time when we see these things in a child in the region, most of the time we are dealing with pediatric glaucoma. But sometimes, a small percentage of the time, we're dealing with a mimicker. When diagnosing pediatric glaucoma, we have to look at all examination parameters. Don't look just at the IOP. We have to look at all parameters. We have to put them together, and everything should make sense. If it's not making sense, maybe we're dealing with something else. Conditions that mimic pediatric glaucoma should always be considered in any child where the diagnosis of pediatric glaucoma is given. Again, most of the time, the diagnosis of pediatric glaucoma is obvious, and there's no reason to hesitate. But I run through my mind every time I diagnose a child with glaucoma, am I sure this is glaucoma? Is there any way it could be something else? And in my experience, the two conditions that are most often mistaken as pediatric glaucoma in the region are CHED, congenital hereditary endothelial dystrophy, and that periventricular leukomalada associated optic disc cupping that we see in children sometimes who are premature. Finally, untreated amblyopia is the number one reason for visual loss in pediatric glaucoma and pseudoglaucoma. Cycloplegic refraction is important not only in treatment of these patients, but also in diagnosis, because when you find an unexpected hyperopia, you have to think twice, are we really dealing with glaucoma? So that brings me to the end. Thanks again for having this forum and including me. It's really my pleasure to participate. Thank you for listening.
Okay, thank you, Dr. Arif, for this nice presentation that I'm sure has enlightened the audience. I have a few questions here. The first question, Do you think reversal of the cup disc ratio, is it only the picture of the disc that comes to be, looks to be normal, or also the function of the disc?
No, you do get, well, first of all, it's very hard to say because this happens in very young children. So it's hard to, measure their function. But I think what's happening is, first, with the increased intraocular pressure, the lamina cribrosa is moving back, and there's a pressure on it. Just like, in a patient who has increased intracranial pressure and has papilledema, there's pressure on the disc. And if that pressure is left, you start to get optic atrophy and loss of axons. But if you catch it early, it recovers because children are young and healthy. So that's what happens in papilledema, and I'd say that's the same thing that's happening in children because they're young and healthy. You've got pressure on these axons, they're under stress, you relieve it soon enough, they're young and healthy, they recover, but if it's too long, they die, and then once they're dead, it's over.
Good. Also, we have a question from Dr. Shada, I believe from Saudi Arabia. So do you rely on the corneal thickness in diagnosis of CHED only as the main factor?
Well, thank you for that question. Corneal thickness is very helpful. It's unusual for a patient with CHED to have a corneal thickness of less than 1 millimeter. They're usually 1 millimeter plus. Yeah. But no, they have a characteristic haze. When you look at the cornea, there's this mosaic haze that's very, very characteristic. It's different from the haze that happens in corneal edema from increased intraocular pressure. And the other thing that's almost like a diagnostic thing in of itself, when you take a picture of these corneas, you get this bluish discoloration that you don't get in the corneal edema from congenital glaucoma. And I almost use that as helpful in my diagnosis itself. I just like to take a picture of the cornea and I look at it. And the way that reflection is in CHED, it's different from the way it is in congenital glaucoma. So to answer the question, it's not only the thickness, but if the thickness is less than 1 millimeter, I'll think twice. If it's greater than 1 millimeter, it's almost certainly CHED without even doing anything further. But, again, we always want to look at everything.
Of course. The other question from the audience, from Dr. Muhannad Labdour again, is there any specific guidelines in interpreting OCT of the optic disc in children, different from adults, maybe?
That's a good question. The literature is much less in children than in adults. I do like to get OCTs, and basically I just would follow them serially, looking for changes. Other than that, I don't really have much guidance. The problem is children can have congenital optic nerve abnormalities. So if you have a child who has a nerve fiber layer defect and some cupping, and you demonstrate it on OCT, it's possible that was a congenital static defect. So you can't jump to the conclusion that you're dealing with glaucoma. The periventricular leukomalada is a perfect example of this. That's a static optic nerve abnormality. So I would say the guideline is you really have to follow for change. Just because there's an abnormality there that seems to be glaucomatous, it doesn't mean that it is. It could be something congenital and static in a child.
Good. The other question, can brittle cornea show as a blue sclera sometimes? Does it have blue sclera as a feature?
Definitely, yeah. Some children with the brittle cornea syndrome have blue sclera. I think that, obviously the connective tissue of the eye, particularly the cornea, is weak and thin and ectatic, and it affects the sclera in varying degrees as well. But it's not the blue sclera that you see like you might see in osteogenesis imperfecta, which is very dramatic. Yeah. It's less dramatic. and even seems to get a little bit better with time.
Okay. Any questions from the audience? Maybe you can speak directly to to Dr. Khan if you want.
Dr. Raed?
Yes.
This is Tawfiq. I think there is a question. It's sent twice with corneal haze and difficulty seeing the optic disc.
Okay, so this is the question
from Dr. Asim, yes.
Okay, so with corneal haze and difficulty seeing the optic disc, what factors do we depend on to differentiate between congenital glaucoma and CHID with high measured IOP? Is it only the corneal diameter, measurement, thickness?
Well, this is a great question. I think the biggest issue is, first of all, most of the cases of CHED that we see in the region are quite significant, and they're present at birth or soon after birth. It's not that it develops a little bit later. So if a child didn't have corneal haze previously and then starts to develop corneal haze, I'd say it's less likely to be CHED. Now, the biggest conundrum, the biggest problem that happens is that a baby is born, the corneas are hazy, the pressure measure is high.
Yes.
The parents are anxious. The doctor is anxious. Everybody is anxious.
And nobody wants to wait for the diameter of the cornea.
Nobody wants to wait. The parents are pushing, do something, do something. They're crying.
All right.
I will tell you, I would much rather wait and observe in a situation like that, if I'm unsure, than do an unnecessary surgery. And I wish I could tell you that you look at the patient and you have all the answers. But congenital glaucoma, especially pediatric glaucoma, you have to accept that you might not have all the answers in one visit. And I think the mistakes occur when the doctor feels he or she has to do something and make all the decisions in one visit. I showed you that case of the patient who came in with a pressure of 40, and I treated them with glaucoma drops, and then a week later the pressure was 10,
yeah.
And it turned out to be a block of the pupillary block. I didn't realize it was a pupillary block when they first came in. I thought they had primary congenital glaucoma. But I did not take them to the operating room because I don't feel comfortable unless I have examined everything. And I didn't get a good view of the fundus, and I didn't get a good retinoscopy. I wanted to at least get a good retinoscopy before taking them to the operating room. And I was shocked when they came in a week later and the pressure was 10. I was in shock. And I didn't suspect that the patient had that LTBB2, the pupillary block. But because I didn't have everything in the beginning, I needed more information, waited. Had I not waited, had I taken that patient to surgery, I probably would have done an angle surgery and it would have been a disaster. So going back to the CHED, if I have a baby who has corneal haze, I can't see inside, there's no megalocornea, I'm not going to do surgery unless I'm sure it's not CHED. I'm going to wait. You have to. The choice is, the other choice is doing an inappropriate surgery. You can follow them with ultrasound. You can follow for ocular enlargement. It's tricky. There's no, it's not like precise mathematics engineering. It's more like cooking. You can put a pinch of salt, you can put a pinch of pepper, when it's not precise that, we do this and we do this in one visit. So to answer the question is, I would wait if I'm not sure. I have to be sure. I don't want to operate on somebody who doesn't, for glaucoma, who doesn't have glaucoma. especially a baby.
Okay. So we have a question here. How do you do genetic testing on those patients? Do you ask for a specific gene investigation, or how do you request the genetic testing for those patients in doubt?
Well, it depends what you're doubting. For genetic testing in general, you have to have a suspicion of what you're testing for. For CHED, it's very specific for mutations in SLC4A11. So if I suspected CHED, I would test for mutation in that gene. And I'll tell you, I have done that in some patients. There have been some patients where I haven't been sure. And the problem is genetic testing takes time. It's not something you'll get quickly. But if it's something I have access to, I'd like to do it. The problem is genetic testing is helpful if it's positive, but if it's negative, it doesn't help you. So
it doesn't rule genetic problem, right?
It doesn't rule out. If it comes back negative,
yeah,
it doesn't help you. Now, I have to say, every single patient that I've ever suspected of having CHED has come back with mutation in SLC4A11 without exception. There was one that didn't, and then they did it again, and they found out they made a mistake before. So the SLC4A11, the CHED is very, very specific. For the other conditions, what I would do actually to something more practical, the major cause of glaucoma in the region is CYP1B1 mutations. And if you're not sure if you're dealing with glaucoma or not, and you want to do some sort of genetic testing, you could test for CYP1B1 mutations. If it comes back positive, you're most likely dealing with glaucoma. But if it comes back negative, it doesn't tell you that you're not dealing with glaucoma. Dealing with these patients is not managed by genetic testing. Dealing with these patients is phenotype driven. It depends on what you see. Genetic testing is interesting. It can be a supplement, but primarily it's your clinical diagnosis. I wouldn't, with very, very rare exception, I wouldn't rely on genetic testing in making treatment decisions. I would rely on what I'm seeing in front of me.
Right. The other question, would you go for surgical PI instead of lens surgery for pupil block? I think you said that the problem was in the lens moving back and forth, right? So would you elaborate more on this?
Well, this is specifically with LTBB2 mutations. Yeah. I'm talking specifically about this. I'm not talking about ectopia lentis in general. LTBB2 mutations cause fragmentation of the zonules. There's basically, for 360 degrees, the zonules are fragmented. The lens is being suspended by the vitreous because the child is young. They have a very formed vitreous. In that specific condition, the only treatment is removal of the lens.
Yeah.
There's no role for PI. There's no role for anything else. And I'm talking about this specific situation. There are other causes for ectopia lentis. There are other causes for pupillary block. And for those other causes, there may be a role for iridectomy. But for this specific condition where there's 360-degree fragmentation of the zonules, the only solution is to remove the lens.
So, Dr. Arif, back to the genetic testing. Do you ask the geneticist to look like, for example, I have a congenital glaucoma or I have a suspicion of CHED syndrome? Do the genetic testing, or you write a specific gene to look for, or mutations or whatever?
I don't think the geneticist is, I do this, for me it's specific. But again, it's not, I wouldn't, if it's not something that someone is doing regularly, I would ask somebody who has experience with genetic testing to help guiding. But I want to reiterate a point that I made. The decisions in managing these patients is not based on genetic testing. The decision in managing these patients is based on the phenotype. But if if you want genetic testing to help you as a supplement, I would, if it's not something you're doing a lot of, I would refer to somebody to do that, because there are a lot of pitfalls in the genetic testing. You can order something, it comes back negative, it's really positive. I mean, you don't want to be burdened with all of that. I would concentrate on the clinical phenotype, and I would refer to, the problem is a general geneticist is probably not going to help you that much. It would have to be someone who's attuned to ocular genetics.
Of course. Good. So also another question from Dr. Shada. I have a family with 2 children. One has congenital glaucoma and the other has congenital cataract. Is there a relation between the two? The boy with the glaucoma tested positive for PAX6. You think they are related, the cataract in the gear? And,
well, you know, that's interesting. You know, PAX6 mutation we associate with classical aniridia, of course.
Yes, aniridia, of course.
But, you know, a PAX6 mutation has such a variable expressivity. And one of the first phenotypes ever described associated with PAX6 mutation was congenital cataract. So absolutely, and I've had patients who have just congenital cataract and they had PAX6 mutation. So absolutely, PAX6 mutation can cause cataract in one child, and then in another member of the family can cause another phenotype, can cause the glaucoma. Now, PAX6 mutation usually doesn't cause a congenital glaucoma. Usually it's juvenile. Yeah, I don't know if that patient, if Dr. Shatta, if that other patient had congenital glaucoma or a juvenile glaucoma. But absolutely, PAX6 mutation can cause glaucoma in one child, but it's typically not congenital, and cataract in the other. But if these are 2 boys, I would be more worried about Lowe syndrome. Mutation in the gene that causes Lowe syndrome, because Lowe syndrome mutations in that gene on the X chromosome can cause cataract and can cause glaucoma.
Is it the same as the oculocerebrorenal syndrome?
Yeah.
Lowe?
Yeah. So, Dr. Shatta, did that patient have congenital glaucoma, or was it a juvenile glaucoma? If she's still there.
Yeah. Can I? Maybe I can talk. It's easier.
Yeah, great.
Yeah. So I took care of the girl who came to me with congenital cataracts at about 3 weeks of age. And then I found out that the family had another child with who's an older sibling who's around 3 or 4 years of age, and he had congenital glaucoma and was tested positive for PAX6. I don't know anything about the boy, but it would be interesting to. I was thinking of sending the girl for genetic testing because that's the girl I'm taking care of. So I thought, is it necessary or not in this situation?
It's not necessary. Unless you want to give family counseling. It's unusual for PAX6 mutation. You know, this would be a missense mutation in PAX6. It would be unusual to cause congenital glaucoma. It could be a completely different disease. Sometimes we see more than one disease in a family. But it is possible. The thing that kind of bothers me a little bit that it's a congenital glaucoma, because usually PAX6 mutation causes juvenile glaucoma, especially a missense mutation, because if it were, you know, a loss of function mutation, a non-missense mutation, then you would have the classic aniridia phenotype. So you have to be careful, because sometimes also you get a report that says that there's a mutation in the gene and it's not really a mutation. Even if the program predicts that it's a mutation, sometimes it has nothing to do with the phenotype. So it's tricky. Somebody has to look at the whole thing very carefully.
Arif from Abu Dhabi, from Cleveland Clinic Foundation. Thank you, Novartis. Thank you, the audience from neighboring countries from all over the world. And hope to see you again in Jordan, face-to-face, personally, rather than seeing you online.
Thanks for this opportunity. It was really a lot of fun. It's a pleasure to be here. Thank you again, Novartis, for this forum.
Thank you.
I believe the lecture was recorded, Tawfiq, right?
Yes, of course, Doctor. It's
So
recorded,
want,
and I will send it to you. Yes.
Okay. So, Arif, I will send it to you in 2 days if you want. We can upload it to YouTube if you want also.
Sure, whatever you want. Yeah.
Okay, good.
Okay. Thank you.